Hello everyone, let's start with strabismus revision by this video. This is the first of 3 videos about strabismus revision. The first one will be introduction about the sensory and the motor aspect. Also, I'll go through amblyopia. Also, I'll go through the evaluation of strabismus. And the second video will be about the esodiviation and completing the evaluation of strabismus. And the third one will be about exodeviation and also the patterns. Okay, so let's start here by the introduction, which is the motor and the sensory aspects of strabismus or extraocular muscles. Here, extraocular muscles anatomy, positions of gaze and binocular movement. This is the motor physiology or the motor issues or motor aspects of extraocular muscles. The sensory ones or sensory aspects will be binocular, single vision, and amblyopia. Okay, after this introduction, as I told you, I'll go through evaluating a case of strabismus. So let's start with extraocular muscles. Actually, I don't care a lot about extraocular muscle anatomy. This is a visual sciences topic. This is not frequent or not mentioned in the exam curriculum. Okay, this is not mentioned in or frequent in the clinical exam. It is frequent in the basic sciences or visual sciences exam, but it is not frequent here. So we won't care a lot about the anatomy. But we don't care, as you see here, we care about the origin, the insertion of the extraocular muscles, although they are extreme for strabismus surgery, but this is not, as I told you, this is not important in the exam. But we will go through the action. And for the horizontal muscles, I don't have any problem. I don't have any problem because I have only one action, being or having the medial rectus muscle here, which is adductor, and the lateral rectus, which is adductor. So here I always have one action because they are always parallel to the optical axis. This is the optical axis, for example, and this muscle, for example, is lateral rectus, and this is medial rectus, for example. So this is not problematic. The problem is in the vertical muscles, which have more than one action. They have actually 3 actions. They have primary, secondary, and tertiary actions. And to memorize this, let's make 5 rules. The first one is about the recti muscles. The recti muscles have an angle which is 23 degrees to outside, something like that, with the optical axis. So here, this is the axis of the rectus muscle, which is 23 degrees. This is the temporal side, and this is the nasal side. Okay, so here the optical axis, if the eye is abducted, will be parallel to the muscle axis. So the muscle will be elevator and depressor. This is about the recti muscles. So the primary action is elevation and depression, and the secondary action will be intorsion or extorsion. And this intorsion and extorsion will occur when the eye or when the optical axis is perpendicular to the axis of the muscle. Okay, this is not these details are not that important, but here you can memorize that the recti muscle have primary and secondary actions. The primary action is what? It is elevation and depression, and the secondary action is intorsion or extorsion. About the oblique muscles, it is the reverse because they make a larger angle here. They make an angle which is what to the optical axis? It is 51 to the optical axis, but to the medial side. This is nasal, this is temporal. So here it is easier for the eye to be perpendicular to this muscle. Okay, so the optical axis is easier to be perpendicular here when the eye is abducted. So the primary action will be intorsion or extorsion, and the secondary action will be the reverse elevation or depression. Okay, so the recti are in contrast to the oblique muscles. This is rule number 1 and rule number 2. Rule number 3, all superiors are intorters and all inferiors are extorters. So I have intorters which are superior rectus, superior oblique, extorters which are inferior rectus and inferior oblique. Rule number 4, which is about where is the main elevator and the main depressor. Here, the elevators of the eye are superior rectus and inferior oblique. The depressors of the eye are inferior rectus and superior oblique. This is known, okay, and this is easy. But how to isolate these muscles? In cases of abduction, In cases of abduction, the recti muscles will be parallel to the optical axis. And in cases of adduction, the oblique muscles will be parallel to the optical axis. So in cases of abduction, the recti muscles will act by elevation or depression. And in cases of adduction, the oblique muscles will act by elevation or depression. So the main elevator in abduction will be the recti muscles, and the main elevator in adduction will be the oblique muscles. Rule number 5, it is about the tertiary action. This is not important. This is not important at all, but we can remember this mnemonic, which is ob-ab. Obliques has a tertiary action of abduction, and for the recti muscles will be adduction. So the obliques will be abductors as a tertiary action. This is ob-ab mnemonic. Okay, these are the 5 rules. You can just memorize this in order to memorize anything. And for me, it is very important to memorize this one. Here, I want to know the cardinal positions. The cardinal positions here, one muscle is isolated in each position. Here it is the medial rectus in abduction, and here it is the lateral rectus in abduction. Look at the superior and the inferior positions. Look at these. The superior, in the superior position, elevation in adduction, you know, this is inferior oblique. Elevation in abduction, you know, this is superior rectus. Depression in adduction, this is superior oblique. Depression in abduction, this is inferior rectus. And this is what I told you in order to isolate, just isolate one muscle action. You should know what is the main elevator in abduction, what is the main elevator in abduction, and so on. Okay, here these are hints from Dr. Kenneth Wright about the clinical tips of the extraocular muscle anatomy. Here I have for the medial rectus muscle, it has 3 short tests. It has the short distance to the, and it has the short tendons because the inferior tendon, inferior oblique has no tendon, almost has no tendon. Even the inferior oblique will be the shortest at all. But when I'm talking about the rectus muscle or the recti muscles, here it is the medial rectus muscle. Also, it has the shortest arc of contact, and this has a clinical tip or a surgical tip. Here, look at this arc of contact. Here for the medial rectus, it will be small, and look at the lateral rectus, it will be the largest here. And this will make the Fadden procedure effective. What is the Fadden procedure? It is posterior fixation or suture posterior fixation, like that. I'm fixing a suture here. This won't alter the primary position, okay, but this will decrease the action of the medial rectus muscle, as if I'm doing recession but without recession. Okay, so this is called what? This is called Fadden procedure. And Fadden procedure is the correct name. It is not Fadden suture, because Fadden in German means suture. So it is not called suture. It is suture operation or posterior suture operation. This is Fadden procedure. Okay, and this is indicated in cases of concomitant strabismus, like that of 6th nerve paralysis. Okay. Also, the medial rectus has no connection to other muscles. By the expression of Dr. Kenneth Wright, it has no friends. Medial rectus has no friends. Okay, and this makes the medial rectus slippage very difficult. It is the most commonly lost muscles and most difficult to find because it has no friends. Actually, the lateral rectus will be related to the inferior oblique, as you see. Also, the inferior rectus will be related to the inferior oblique. The superior rectus and the superior oblique are related to each other, and the medial rectus has no friends. So, slippage or loss of this muscle will be a very difficult situation. About the lateral rectus, has the longest arc of contact, and here mean that the Fadden procedure won't be effective for this muscle. Okay, so the lateral rectus Fadden procedure won't be effective. I want to repeat this more and more. Connection to the inferior oblique muscle, and this makes slippage or loss of this muscle not that problem or not that difficult like that of the medial rectus. About the oblique muscle, or sorry, inferior rectus muscle, it has relation to inferior oblique as well. Here it is the inferior rectus, and here it is the inferior oblique. As you see, they are related to each other, and they are related also to the capsulopalpebral head of the eyelid and the capsulopalpebral fascia, and also the Lockwood ligament or ligament of Lockwood. These are all inferior attachment, and they are all related to the inferior rectus muscle. This is important because if you see some fundus, you will find the normal appearance will be the center of the fovea just below the center by 1 millimeter at most, but just below below the center of the optic disc. So the center of the optic disc is slightly higher than the center of the fovea. Okay, if you don't see something like that, something like this case, you will find that the fovea is higher. This means what? This means that you have intorsion. Okay, if the fovea is higher, you mean that you have intorsion. If the fovea is lower, you mean that you have extorsion. Okay, so you can memorize this because this is important in questions. Okay, if you find that the optic disc is higher, this means that this eye has extorsion. If you see that the fovea is higher, something like that, this means that you have intorsion. Okay, what muscle or muscles are overacting? Here in intorsion, I told you that all superiors are intorters, so the muscles are superior oblique and superior rectus. So this is the correct answer. Here you can see this extorsion. You can see that the optic disc is much higher than that of the center of the fovea. Okay, so here, which muscle is weak? It is the intorter one. Also, it will be the superior oblique muscle, because here the eye is extorting and the weak muscle will be the intorter one. Also here in this photo is missed, sorry. It is not due to change in the format, but here let's imagine that we have here trochlea like that, and here it is the superior oblique muscle. Before it is inverted here through the trochlea and inserted into the sclera, something like that. This is the globe, something like that. This is to imagine this photo. Here, the posterior 2/3 of the muscle will be levator and depressor. For the superior oblique, it will be depressor, and here the anterior 1/3 will be rotator. It will cause intorsion. Okay, so in cases of fourth nerve palsy, which is supplying this muscle, I just advance this part, which is the anterior part, to correct exodeviation. Sorry, to correct excyclotorsion. So in cases of excyclotorsion due to fourth nerve palsy, I just advance this anterior 1/3, and this operation is called Harada E2. Can you see this one, Harada E2? I just advance the anterior part, and the anterior part advancement will cause intorsion to the extorted eye. Okay, let's talk about the positions of gaze. This is the end of the extraocular muscles. About the positions of gaze, it is extremely easy. I have the primary position when the eye is straight ahead here like that. This is the primary position. And also I have 6 cardinal positions, because in each of these positions, I just have one muscle action. Okay, so let's imagine that we are talking about this eye, which is the left eye. When I'm looking to the left, I'll work by the lateral rectus. When I look into the left and up, this will be by the superior rectus. Okay, when I'm looking to the left and below, this will be by the inferior rectus. Okay, when I'm looking by this left eye, when I'm looking to the right here, this will be by the medial rectus. To the right and up, this will be by the inferior oblique. To the right and down, this will be by the superior oblique. So these are called the cardinal positions, in which I can isolate one. I have also, rather than the cardinal positions, I have the upward, straightforward, or upward, direct upward gaze and downward gaze. In upward gaze, I have superior rectus and inferior oblique acting together with each other. So they are helping each other. Also here for this eye. Okay, so here I cannot isolate. So this is called upward gaze and downward gaze. Also, I have near fixating gaze, in which the eyes are convergent, somehow convergent due to the near reflex. Also, I have two laws of regulating the action of the extraocular muscles. I have here Sherrington law, which is called reciprocal innervation. Here, Let's imagine that this eye is the left eye, and I want to look to the left. So I have to act by contracting this lateral rectus muscle. This contraction will be accompanied by inhibition to the antagonistic, which is the medial rectus muscle, in order to make the muscle movement smooth. Why the muscle movement is smooth? This is a question because of the reciprocal innervation. When I'm contracting the agonist, the antagonist must be relaxed. Okay, so this stimulatory wave is accompanied by a simultaneous inhibitory wave here. This is called Sherrington law. Okay. Also, I do have hearing law here for what I'm calling the conjugate eye movement. If two eyes, both eyes are looking here to this direction, they are working in the same direction. So here I'm working by the lateral rectus and here by the medial rectus. So the lateral rectus of the left eye and the medial rectus of the right eye are contralateral synergists, are synergistic to each other. They are called yoke muscles. So yoke muscles mean that these muscles has the same direction. Also, when I'm looking here, for example, to this position, which is to the left and up. For the right eye, I'm working by inferior oblique muscle. For the left eye, I'm working by superior rectus muscle. So these muscles also are what? They are contralateral synergists or yoke muscles. And these muscles work on the same direction as you see. They share the same direction. Okay. So this is what we call yoke muscles and hearing law. Hearing law means that I have simultaneous and equal innervation to yoke muscles. When I'm looking to the right, I'm looking to the right by both eyes. This is hearing law. Here I'm looking to the right by my left eye and by my right eye, and simultaneously. Okay, this is the hearing law for the conjugate movement. Okay, this is Sherrington law, which means that contracting the lateral rectus or shortening the lateral rectus will be accompanied by inhibition of the medial rectus. Okay, also the hearing law here, you can see that both eyes are moving here to the left, something like that. For the binocular movement, I have conjugate movement, as I told you, versions, and I have this conjugate movement, which are called versions. Okay, so conjugate movement, when both eyes are looking upward, downward, or upward and right, downward and right, upward and left, downward and left, to the left or to the right. So both eyes are working in the same direction. This is called conjugate eye movement. What about this conjugate movement? Both eyes will work on opposite directions, like convergence and divergence. Here in convergence, both eyes will move to the opposite direction. So the right eye will go to the left and the left eye will go to the right. This is called convergence. What about divergence? Divergence here means that both eyes will be moving to the same direction. Not the same direction, opposite to each other, but they are working, or the right eye will go to the right and the left eye will go to the left. This is called what? This is called divergence. Okay, so conjugate movement means that both eyes will move to the same direction, but this conjugate movement means that both eyes will move to the opposite direction. About the binocular single vision, this is a physiology one, so we can skip this, but the requirements of the binocular single vision is important for me. Okay, I have requirements for binocular single vision. Binocular single vision means principally that 1 + 1 = 1. I have one image from the right eye, one image from the left eye, and the net result will be just one image. Okay, so the net result is 1 because of what? Because I have more than one requirement. I have sensory requirements, which is requirements of the object or the image. The images must be of the same focus or the same sharpness, the same shape, the same color, and the same size. These are all requirements of the image. And also, I must have what we call normal retinal correspondence. You can imagine that this is the eye here and this is the retina here. Both retinae are mirrors to each other. So when I stimulate the fovea of the right eye, here it is the fovea of the left eye, I suppose that the fovea of the right eye will be stimulated by the same thing. Okay, this means that the fovea of the left eye and the fovea of the right eye are paired points. Okay, or are corresponding points. Here, when I stimulate a nasal element of the left eye, this is accompanied by stimulation of a temporal element of the right eye. This is logic, and this is called normal retinal correspondence. So both retinae are mirrors to each other. Having the nasal retina mirror to the contralateral temporal retina, and the temporal retina contralateral to the nasal retina. This is mirror to the contralateral nasal retina. Okay, so this is normal retinal correspondence. And this is a requirement for having binocular single vision in the normal circumstances. But in cases of strabismus, maybe the abnormal or anomalous retinal correspondence may retain some binocularity. Okay, so this is important. So here it is the requirements: sharp images, similar size, similar shape, and similar color. Okay, the images must fall in corresponding points or paired points. I have also normal pathway, normal motor pathway, and normal extraocular muscles. These are all requirements for having binocular single vision. And this is physiology, pure physiology about the binocular single vision. This is not that important in the clinical sciences, but here I have the fixation point, and from this fixation point, I have empirical horopter or empirical imaginary horizontal line, which is called horopter, in which each point will stimulate corresponding points and each point will be seen as just single point. Okay. Also here in this area, which is called the Panem area, which is here in gray, this area, if I stimulate this or this or this or this or this, I can have some horizontal disparity, but I still have binocular single vision. And this is responsible for what we call stereopsis, because I have some disparity, but I see more than one aspect of the same object. Okay, this is called Panem's area. But outside this Panem's area, like in this point and this point, I'll stimulate non-corresponding points. Look here, number A, I'm stimulating what? I'm stimulating temporal retina in the right eye and temporal retina in the left eye. And I know that the temporal is mirrored to then the nasal in the other eye. So here temporal and temporal are not corresponding points. So when I'm stimulating non-corresponding points, this will result in diplopia. Okay, so here in this area and in this area, I'll get diplopia. But here in the Panem fusional area, I have binocular single vision and stereopsis. Okay, that is for the Panem's area. Can you see this one? Here, this is single vision. This is also single vision, but with stereopsis. But here I have diplopia and here I have diplopia. So if I'm further to the, or if I'm beyond the Panem fusional area, I'll see diplopia. Let's go to worst classification of the binocular single vision, which is 3 grades. The first grade is simultaneous perception. I must see by my right eye at the same time that I can see with my left eye. Okay, this is called simultaneous perception, and this is grade 1 of binocular single vision, by which when I'm applying this to the synoptophore, I can see that the bird is inside the cage. Okay, and the grade 2 of binocular single vision is fusion. Also by the synoptophore, when I'm looking by one eye at a rabbit, having a tail here by one eye, and the other eye will see the same rabbit but without the tail, but this rabbit is holding flower. So I'll fuse the one in common, which is the main rabbit here. Okay, and one eye will see the tail and the other eye will see the flower, and this will result in just with a tail and having a flower. This is called fusion. I have fused both images. Also, the stereopsis, if I have a bottle, for example, and I'm looking to by one eye to the top of the bottle and the other to the bottom of the bottle, I'll see just one bottle having depth, having top above, having bottom below, and this is called stereopsis or depth perception. Also, I have something called binocular rivalry and suppression. What do you mean by binocular rivalry? Here, in cases of strabismus, in cases of squint, look at this eye. This is a straightforward eye, something like that, which is looking to a square like that. And this is a deviated eye. Look at this one. It is looking to a circle like that by the fovea. So here the fovea is seeing a square, and the fovea of the left eye here is seeing a circle. And what is the result? The result will be confusion between the circle and the square, because the fovea is paired with the other fovea. In cases of normal retinal correspondence, I have here pairing between these area. So I'll see the square over the circle, or the reverse, the circle over the square. Or sometimes I'll see, sometimes I'll see the square, and sometimes I'll see the circle. Until what? Until I do suppression to the squinting eye. Here I'll do central suppression to eliminate the confusion and see just this square. I'll eliminate the circle view. Okay, so I do central suppression in order to eliminate confusion. Confusion means retinal rivalry. So retinal rivalry and confusion are almost the same. They are a result of squint. Also, in cases of strabismus, I may see diplopia. Let's imagine here that the right eye, again, it is straightforward. Here it is looking at this object like that. Okay, and look at the left eye, which is isodeviated like that. Here, this is the optical axis, or the visual axis of this eye. This visual axis is here, and this part or this point will be temporal to the visual axis of the left eye. Look at this one. This is temporal, so it will stimulate a nasal part, okay, nasal element of the retina. And this will result in more temporal location, or more temporally location image. This is called diplopia. In order to eliminate this diplopia, I must do peripheral suppression like that. This is called peripheral suppression. Okay, so I do central suppression in order to eliminate confusion, and I do peripheral suppression in order to eliminate diplopia. Okay, what about the anomalous retinal correspondence? What do you mean by anomalous retinal correspondence? In cases of strabismus, look at this one and look at this one. In cases of strabismus, here the fovea is seeing this part, and here the fovea is looking at this part. This part is considered temporal to the left eye. This will stimulate a slightly nasal element, okay? But the brain will see that this part or this fovea has an image, and this nasal part has the same image like the fovea. So the pairing will be between the fovea and this nasal part. So I'll change the mirror. I'll shift or drift the mirror. Here, this will be the new fovea of this patient. Actually, this is not the most important part or the most important element, retinal element. The most important retinal element will be the same. It will be the fovea. But this part will be paired with the fovea of the normal eye. Okay, so here the fovea of the normal eye will be paired by another retinal element or extrafoveal retinal element. This is called anomalous retinal correspondence. And this is done why? Because I want to see clearly single vision. I want to see binocular single vision. So this is considered an active adaptation from the brain in order to see things as being one. So here, this is called anomalous retinal correspondence. I changed the map of the retina or the mirror of the retina somehow slightly to the nasal here like that. Okay, so this is called anomalous retinal correspondence. What the difference between ARC and eccentric fixation? This is viva or oral one. Eccentric fixation is monocular process. So here, in cases of eccentric fixation, and which is caused by foveal amblyopia or caused by foveal scar or something like that, here I don't have any fovea. So the eye has to deviate something like that in order to stimulate another area rather than the fovea. Okay, when I cover the sound eye, when I cover the normal eye, this eye won't retain fixation because the fovea has suppression or amblyopia or scar. Okay, so here this is a monocular process, which is eccentric fixation. What about in cases of anomalous retinal correspondence? When you do the cover test, look at this one. Here, this is the first eye, and this is the second eye. Look at this one. When you do what? When you do cover testing here, this is the squinting eye like that. When you do cover test to the sound eye, this eye will retain fixation because the fovea of this eye is normal. Okay, but all what we have done is that we have paired between the fovea of the normal eye and extrafoveal element of the other eye in order to retain binocular single vision. Okay, this is the main difference between eccentric fixation and anomalous retinal correspondence. This is the question here. What is the difference between ERC and eccentric fixation? I told you this before. Here, this is the problems of strabismus. I have confusion here. The left eye, which is normal, will see a square. The right eye, which is deviated in or iso-deviated, will see what? Will see a circle, and the result will be a circle inside the square, something like that. Okay, or sometimes I see the square and sometimes I see the circle, and this is called retinal rivalry. How can I eliminate this? By suppressing or by acting by suppression to this right eye. Okay, also here for the diplopia, can you see that the left eye, which is normal, is looking to the black circle like that, okay, by the fovea. But this deviated eye, which is the right eye, is looking inward. Can you see the visual axis, which is dotted here? This is the dotted line. Okay, when you see this, remember that this is called, or this is considered temporal to the visual axis. So it will stimulate a nasal element to be seen more temporal like that. Okay, this is called diplopia. How can you eliminate diplopia? You just suppress this area, which is peripheral part. So, confusion is eliminated by central suppression. Diplopia is eliminated by peripheral suppression. Here, suppression is cerebral neglect of the image seen by the squinting eye. It may be temporary and it may be absolute, or maybe all the time. So prolonged suppression may lead to amblyopia. Here, the sensory adaptation to strabismus, either by suppression, I told you, or by anomalous retinal correspondence. Suppression is called passive adaptation to strabismus, and ERC is called active adaptation to strabismus. Okay, here, what the difference between depth perception and striopsis? Here, depth perception can be perceived by only one eye by the monocular clues, which is not that important. Here, I'll go through this, but this is not that important. Okay, and the striopsis is the depth perception using both eyes by having retinal disparity or horizontal retinal disparity together with seeing more than one aspect by both eyes. So the right eye will see some aspect and the left eye will see another aspect of the same object, and this is called striopsis. The monocular clues that I can use in order to detect the depth by only one eye, it is the relative size. Can you see that this is the farthest because it is the smallest interposition? You can see that this is the posterior one and this is the anterior one because this is anterior because the posterior one is hidden. The bottom of the posterior one is hidden. Texture gradient, can you see the spacing here? You mean that this is nearer than these? Here I don't see any spacing. Linear perspective, also here you can see that these are wide and these are narrow. Also aerial perspective, you can detect that this house is in front of this mountain. Lights and shades, and also the monocular movement parallax, which is a test. We can do this test, but this is not that important. This is important in physiology, not important in the clinical sciences. This is for the introduction of strabismus. Let's go through amblyopia. Here, amblyopia, it is the first topic to be required in the exam. Okay. By definition, amblyopia means that I have decreased visual acuity, but this is not organic. This is not due to organic lesion. Yes, that cannot be attributed directly to the effect of any structural abnormality. Yes, as I told you, this is not an organic lesion to the eye or the visual pathway. Okay, the best corrected visual acuity is lower than that of the normal value. The causes are strabismus, which is a very common cause, also refractive error. Either I have an isometropia, which is difference between one eye and the other, so I depend upon one eye and I'm neglecting the other, or high refractive error, which is isometropia. In cases of isometropia, like that the patient has -10 in both eyes, or the patient has +5 in both eyes, this will result in bilateral amblyopia. Visual deprivation in one or both eyes, this is also a cause, like cases of congenital cataract and so on. Okay, let's talk about the strabismic amblyopia. This is, as I told you, in cases of unilateral, especially unilateral strabismus, because in cases of unilateral strabismus, the brain is only dependent on one eye, which is the aligned eye. And this eye which is deviated is neglected. So I neglect one eye. This will lead to strabismus. And this strabismus will lead to eccentric fixation. So most cases of strabismus or strabismic amblyopia will have an element of eccentric fixation. This is normal. This eccentric fixation, if it is a small amount, it will be detected using some devices like the visuoscope. But if it is detected clinically, so clinically evident eccentric fixation, this will indicate that this patient has a very poor visual acuity, which is worse than 20/200. And this is a question in IDOCS questions. Eccentric fixation or clinically evident eccentric fixation means that the visual acuity is 20/200 or worse. This is important one. Anisometropic amblyopia, which is high refractive error in one eye and the other eye is normal. This is also common, and this may coexist with strabismic amblyopia. So here, this is important in order to treat all cases of or all causes of amblyopia. Either it is strabismus alone or strabismus with anisometropia. The levels of anisometropia that commonly lead to amblyopia, according to American Academy, it is 1.5 diopters for cases of anisohyperopia. So in cases of hypermetropia or hyperopia, I have what? I have a value of 1.5 diopters. So hyperopia here is more likely to develop amblyopia than that of astigmatism and myopia. Here, 2 degrees of astigmatism or anisostigmatism is indicated for treatment because they may lead to anisometropic amblyopia. And here, 3 degrees of anisomyopia. This is also relevant to development of amblyopia. And here, if the levels are higher, this will be associated with greater risk. Stimulus deprivation, this is in case of cataract or media opacities like cataract, here orthosis that cover the pupil. Here, this is called stimulus or sensory deprivation amblyopia. How to diagnose amblyopia? Here, I have low visual acuity and crowding phenomenon. What do you mean by crowding phenomenon? I see that the patient or the child can see the letter alone. He is telling me that this is C with having the opening to the right. This is correct. Okay, and if this C is written beside another C which is looking upward and another C which is looking downward, something like that, this patient won't see either of them clearly. Why? Because of the crowding phenomenon. Here, the crowding phenomenon is caused by increased what we call the perceptive or the receptive field of the same ganglion cell or the same bipolar cell or the same location in the visual cortex is larger. So here there will be some interweaving or some overlapping of the receptive fields. So this will cause what we call crowding phenomenon. Also, the neutral density filter will be almost normal, or it will retain the same visual acuity in cases of amblyopia, and in cases other than amblyopia, in cases of decreased visual acuity due to another cause like cataract or whatever, organic lesion, the neutral density filter will decrease the visual acuity. The worst 4-dot test, here in cases of worst 4-dot test, the patient will see, we will talk about this later, the patient will see just 3 green or 2 red dots. Synoptophore also, the patient will see only 1 image. And in the visual evoked potential non-verbal children, this is a method for detecting the visual acuity or assessing or assessment of the visual acuity in cases of non-verbal children. And this is done. This is done in non-verbal children, as I told you. This is, we can diagnose amblyopia by this one. In general, the visual acuity in general, okay? What about the treatment? It is occlusion therapy. And here the occlusion therapy, the squinting eye, or sorry, the sound eye is covered, and the amblyopic eye will be forced to see. Okay, here the sound eye is covered, obligating the child to use the amblyopic eye. This is the idea of occlusion therapy. What do you know about the regime? Is it full-term occlusion or full-time occlusion, sorry, or part-time occlusion? Most of the studies that are comparing between the full-time and the part-time occlusion recommended that the part-time occlusion is almost the same, or has the same efficacy like that of the full-time occlusion. The full-time occlusion is risky because it can reverse amblyopia and strabismus. The patient is coming to me with right amblyopia. The patient after full-time occlusion will have left amblyopia. So this may reverse amblyopia and strabismus. Okay, for severe amblyopia, I do part-time occlusion of 6 hours, okay, per day. And for moderate, I do 2 hours per day. Here, severe mean that severe deficits or severe amblyopia mean that I have what? I have 20, 125, or from this to this, which is 400. Okay. And if the visual acuity is better than this, if the visual acuity is better than 125, I'll just do 2 hours of daily patching. This will be sufficient. This will be effective. So in cases of moderate, I'll do 2 hours daily. In cases of severe, I'll do 6 hours daily. The desired endpoint will be if the patient has the right eye having 6/9 visual acuity, so my target will be getting the left eye having 6/12 visual acuity. So there must be just 1 line difference between both eyes. This will be the endpoint for me. Okay. Also here, occlusion during infancy, reverse substantial strabismic amblyopia in less than 1 month. Here, this is important. For how long? This is a good question. For how long I do occlusion therapy? Actually, in cases of infancy, this will be very effective and very rapid. So just 1 month of treatment will be sufficient to treat the strabismic amblyopia. Okay. Also, for older children, this may have longer time, but here there may be still treatment can still be beneficial beyond the first decade of life. So after 10 years, it is unlikely for the patient to get benefit, but this may carry some prognosis, not that good prognosis, but the patient may have some benefit. So it must be tried also in cases or in children over or beyond the first decade. Some children will have some problem of patching, and they will be bothered by patching. So we can do this alternative way, which is pharmacologic or optical treatment. For pharmacologic treatment, I do the fogging using the cycloplegic to the better eye, cycloplegic Midriatic to the better eye, in order to make some fogging to this eye, and the child will be forced to work by the other eye. Also, I can do something else, which is optical treatment. I can fog using plus lenses. This will be very good option. Okay, I have complications and challenges. Also, this pharmacologic or optical treatment may have also an adverse effect of reversing amblyopia and so on. Complications and the challenges of therapy. I have reverse amblyopia induced strabismus. This strabismus can develop or worsen with amblyopia treatment. Okay, although strabismus can also improve with amblyopia treatment, but here in cases of reverse amblyopia and new strabismus formation, this is a challenge, or this is a complication, because if I'm covering the sound eye, this sound eye will develop another amblyopia and another strabismus, and this will be problematic for this patient. Although normally strabismus can be improved using amblyopia treatment. Okay. The poor adherence here, lack of adherence, it is the commonest one, the most common one. It is a common problem here. It is the most common problem of failure of treatment. Okay, if difficulties derive from a particular treatment method like that of the patching may cause contact dermatitis and so on, and maybe bothering the child or annoying to the child. So you can seek another suitable alternative. Okay. Here it is very important. This is about counseling. It is important for the family to understand two issues. The first one is that amblyopia treatment is performed primarily to improve vision rather than ocular alignment. So the patient or the father comes to me and tell me that my child has patching and his squint is still. I'm telling you that his squint will be still, because here I'm not treating the squint, especially or even sorry for this interruption in my network. My internet connection wasn't stable. So here I was talking about this. This is for counseling. You should tell the parent, should tell the father that your child need to treat the amblyopia either before the surgery or after the surgery, and this amblyopia won't improve. It may improve the ocular alignment, but this is not the main purpose of treatment. The main purpose of treatment is to improve vision rather than ocular alignment. Okay. Also, if you improve the ocular alignment with surgery or with glasses, you will still need to treat this amblyopia. So treatment of amblyopia is extremely mandatory for all cases of strabismus and all cases of amblyopia. Okay. Unresponsiveness, here you do everything, the patient does everything, and nothing occurs. The patient fails to improve vision at all or beyond a certain level. Okay, this is more often in patients older than 5 years. When a child or when a parent comes to me with a child older than 5 years, I am telling him that the prognosis won't be that good. Okay, and here you should try with him from 3 to 6 months at most with good treatment adherence. This is the chance for this patient. Also, the recurrence, which is here, it is extremely important problem. After you treat the amblyopia, the patient improves and the visual acuity is good. After that, this patient or this child comes to me after weeks or after months and complain again of depending upon just one eye. Here, I should reduce the occlusion regimen, not stop the occlusion regimen suddenly. So here it is important to reduce it gradually to 1 to 2 hours per day, and then to 1 hour, and then to half an hour, and so on. Okay, this is in order to avoid recurrence. This is for strabismus introduction and amblyopia. Let's talk about strabismus evaluation, but I'll make the strabismus evaluation and esodiviation in the next, or in the second. This will be the rest of amblyopia. So here we talked about the strabismus introduction, sensory and motor aspects of the extraocular muscles, and then amblyopia. In the next one, we will talk about strabismus evaluation, evaluating the motor functions or the ocular alignment, and then evaluation of the sensory adaptation to strabismus. After that, we will talk about esodiviation. So see you in the next video. Thank you.